This is Dr. Deepeka. I welcome you all to the MRCOG Part 3 back-to-back YouTube series, and the topic for today's discussion is general gynecology. So what I aim to cover in this short video discussion is, since you're around the exam is around the corner, with regards to general gynecology, what are the scenarios you can expect? And some example stations and how to approach each of them, and what is the examiner's expectation in each station, what are the points to be covered and what is not important, what is important, what is not important, and what are all the asterisk points, and what are the common mistakes and don'ts in general gynecology, and also about the tips and tricks to approach general gynecology stations. Now we can delve deep into the stations. Certain scenarios which you can expect I've jotted down, but this is not complete, because general gynecology is a broad specialty where you can get different set of stations. However, the common things are always common, so you should expect common stations, common exam scenarios, or common conditions which you see day to day in your general gynecology practice. Heavy menstrual bleeding with or without increased endometrial thickness, small fibroid, large fibroid, case with adenomyosis. So you have to read the scenario properly and just get a detailed history about the heavy menstrual bleeding and ask if ultrasound is already done, or just advise or suggest ultrasound, and look for the endometrial thickness, look for the ultrasound finding, look for the adnexal finding, any other additional findings. And ovarian cysts, unilateral or bilateral, and with or without high RMI. So CA 125 would have been probably done. So you will be given a case, a woman, a premenopausal or postmenopausal with an ovarian cyst. You have to see the features in the ovary, and in any solid areas. Is it bilateral? Is it ascites is there? So you have to calculate the RMI, and you should be able to arrive at a conclusion whether it is more than 200 or less than 200. So to formulate a management plan. Polycystic ovarian syndrome, it can be mostly it can come in subfertility, but also in a middle-aged woman having high blood pressure or high sugars or a metabolic syndrome. So you have to talk about the long-term consequences. And cervical dyskaryosis with the borderline changes, high-grade changes, vulval dermatosis, lichen sclerosis, lichen planus, and Bartholin cysts, Bartholin's abscess, pelvic inflammatory disorders with fever, acute PID or chronic PID, tubo-ovarian abscess coming with pain, history of fever, and you have a mass in the adnexa and suggestive of tubo-ovarian abscess. So you need to, if it is severe or if it is high-grade fever with increased total counts, you have the criteria, you have to admit her. Or it is mild, you can do an outpatient management. So you have to look at the scenario completely. Endometriosis with indication for surgery, large endometrioma, or endometriosis clinically endometriosis which needs medical management. Gynae ward prioritization, how to do rounds in the gynae ward with a mixture of pre-operative and post-operative patients. So what are the advice you're going to give case-wise? And gynae OT prioritization, you will have a mixture of 5 to 8 complex cases where you have to prioritize what are the needs in each case and how will you perform the case, and important intricate steps in each, and requirements for each case, and the post-operative management, immediate post-operative management. And you can get like, uncommon conditions like MRCOG syndrome presenting with primary amenorrhea, which can be diagnosed, or you are the one who is diagnosing and breaking the bad news. Or Turner syndrome, it's already diagnosed. Turner syndrome coming for some gynecological issues like dyspareunia, or just you're the person who is diagnosing or having a suspicion of Turner syndrome, or who has already done a karyotyping and then come to you and you're breaking the bad news that they are having the Turner syndrome. And a trans woman who's already underwent a gender reassignment surgery, and she's having some complaints like dyspareunia. Or you can get a case of ovarian hyperstimulation syndrome post IVF. and premature ovarian insufficiency, diagnosed or undiagnosed, and they have complaints like dyspareunia or complaints like hot flushes, symptoms of menopause. Or some consent taking before a surgery, be it abdominal hysterectomy, laparoscopic hysterectomy, or vaginal hysterectomy, and premenstrual syndrome is a common station. Remember, the list is exhaustive. I've given few typical stations. Now let's go into few examples. So you are an ST5, Mrs. Annie Williams, 43-year-old woman is waiting outside to see the consultant in the gynecological OPD. She had come 2 weeks with, before with abdominal fullness. She has undergone ultrasound and the blood tests and has come to discuss the result. Remember the consultant. Unfortunately, your consultant got stuck up in his operation theater, so he has asked you to consult on his behalf. So whenever you have a scenario, first look how lengthy the question is and try to read out as much as possible. What is the age of the patient? It's very important. What is your position is very important. And what are all the tests she has done, ultrasound and blood tests, and she is waiting to see the consult. So all these important points you should, when you read itself, you should, imbibe it, and you have to remember while doing the consultation, and you have to take targeted history, explain the condition, and make the management plan. And always they would have given what are all the domains you are assessed on. You should read that properly in any module for that matter, be it general gynecology, urogynecology, whatever it is. So you are assessed on information gathering, communication with the patient, applied clinical knowledge, and patient safety. So as I said, you're given the ultrasound report. It suggests that in right ovarian mass, right? Other things are normal. So in the right adnexa, she has a mass, and her CA-125 is 315. As soon as you see the CA-125 itself more than 315, definitely you know that you're dealing with an high RMI. So you have to prepare yourself in the 2 minutes itself, what you're going to talk, how you're going to talk. So you have to think what are all the information gathering you're going to do in the station, and how you're going to explain. So you have to explain her the ultrasound finding, to explain her the CA-125, and combinedly you have to take RMI and what does it mean? High RMI, what does it mean? You have to explain in a very patient-friendly term, and then explain the further management part. We can just go into a typical consultation flow, right? So introduce yourself, confirm your name, her name and age, greet well. Hi, Annie. I'm Dr. Deepeka. You can call me. I'm one of the registrars, ST5. You can call me Deepeka. So how would you like to be addressed? I'm so sorry, our consultant, he's busy in his theater. He is in the operation theater. Will that be okay if I do the consultation for today? So what I would be doing today is that I will get a brief history about you to know more about you. And I can take you through the ultrasound scan and also the blood test which you've done, and explain what it means to you, and explain to you the further management option for you. How does that sound to you? Then go for information gathering. You ask about the presenting complaints, the leading questions which would help you to arrive whether it is a benign or malignant. Her menstrual history is very important. Ask if she's sexually active, and ask if there is dyspareunia. There's nothing wrong. But do not straight away go and ask without signposting. Is there pain during sex? Do not be so strict. And ask about obstetric history, smear history, and then BMI, which is very important, especially if you're suggesting a surgical management, and if you're referring her. Medical surgery, allergy history is very important, and personal history, family history of ovarian and breast cancer is very important. She's having high RMI, and probably you're dealing with a malignant condition, but you cannot tell at present clearly. Socially, social history, how are you happy at home? You can ask about her partner. If she says partner, stick on to partner. Who do you live with? How are your children? Are you happy at home? And ask a mental history, like how have you been feeling over the past few weeks or so? So summarize and ask permission to examine. Now, Mrs. Annie, so having understood about you, so I'm taking you through the blood test. It suggests that your the hormone, the blood enzyme test which you did is a bit high. And also this in the scan, also the size of the cyst is a bit high. So with the scan finding and also with the blood test, we do a calculation for the risk of malignancy index. Have you ever heard that? This number has come as a bit high, and which is concerning for us. And do you need anyone to be with you so that I can tell this news to you? Are you okay to carry on like this? Then say that this is high. We are concerned that this may indicate a high risk of cancer. So what we can do is discuss your case with a multidisciplinary team of care, the team of doctors, which will involve the consultant gynecologist, gynec-oncologist, specialist nurse, and GP, and we will refer you to a gynec-oncologist team. So you need a referral. So you will be as you can give her this pathway, and she has to be referred to the gynecological oncologist within 2 weeks because she has high RMI. So, she will be suddenly upset. What? Like, I have high RMI. You're telling so many things. What does that mean? She may ask you, oh, because she will interpret that it as a cancer. You're telling high risk of cancer, but she may think it is cancer. So what you have to say it clearly is that the chance of you having a cancer is high. But at present, I'm not able to say whether you have a cancer or not. I'm sorry for being the bearer of this news. Always give a warning shot like, is there anyone with you so that I can explain the report to you? Do you need anyone to be with you? Then, so what then once she comes out of alarm denial, so as you know how to break a bad news, she may be upset, she may be crying. So when all that gives a lot some time for the warning shot, I mean the breaking the bad news, then take her through what she can expect in the gynecological consultation and further. So you may be advised to undergo a surgery to remove your womb along with the tubes and ovaries and take biopsies from your tummy and the suspicious areas. That is called the staging procedure. Okay, then ask concerns. Do you have any questions for me? I know this would be difficult for you to take at this point. And then, if you have any doubts, you can come with your partner or your relative so that I can explain the situation again for you. You can write down the questions and then come to me. I'll be ready to explain it to you. And next time you can fix an appointment with the consultant. And then, so she will have some questions. So how long do I have to live? Or is this a cancer? Am I going to die? Mrs. Williams, I can see the situation is very distressing for you, which is very, very understandable. I have just informed you that the chance of cancer is high. So we, the multidisciplinary team of doctors, will thoroughly evaluate the condition, would give you the best possible solution for the condition, and we will be continuously involved in the care. Cancer doesn't mean death. There are people who have battled cancer and are living a happy life. If you wish, I would give you the links of certain organizations and the support groups where people would have walked this pathway, who battled cancer and are living a healthy life, will share their experience with you. You can put them in contact with the Cancer Research UK Macmillan support group, right? So I think it's time to go to the next station. So your next patient is Helen Martha Perez, 28-year-old woman. She has come with complaints of pain during sexual intercourse. She has an attached GP letter. Your task is to obtain focus history and formulate the management plan. So how do you approach this kind of station? You'll be assessed on information gathering, communication with the patient, and apply clinical knowledge. Look at this station. You have only 3 domains. So always look into the domains which you are assessed on. In some cases, in some scenario stations, information gathering will not be a part. So do not waste time on information gathering, and get a focused information gathering which could alter or which could help you in formulating the management plan to be as as clear as that. So this is the referral letter. It says that some doctor is referring to the gynecologist in the Royal Victoria Hospital. So about the patient, 28-year-old woman, a trans woman indeed. She had underwent gender reassignment surgery 8 years back. She's come with pain during intercourse. So kindly address her concerns and do the needful. This is what GP has written. So now you've understood that this is a trans woman. So always remind yourself you should call as Miss and she. How are you? So it's always think as address it with the feminine gender, female gender, right? So always you should do that. So this is the typical role player history where she's underwent the gender reassignment surgery. Details are there. She's an event manager. Now what happens is that she feels that her vagina is not long enough. She has a partner, Harry, who's happy with her. And she has discharge and she smokes and takes alcohol. No allergy, surgical thing is that she's mentally distressed because of the pain and because of the difficulty in intercourse. So at present, she's not looking for fertility. So this is what is a typical role player history, role player brief, but which will not be given to you. But you should look into the various aspects, not that if she's a trans woman who's underwent gender reassignment surgery, she's come to you for dyspareunia, but she may have other aspects like socially, she may be socially withdrawn, she may be mentally depressed, or she may have some fertility questions in her mind. So you have to think, you should have that lateral thinking. This may not be her only concern. So you should ask for concerns. It shows that you are a very safe person. It shows that you are concerned about the patient in front of you. All right. So this woman, trans woman, she may have some questions. Why is the pain and discharge due to? Should I be scared? And can I get rid of my excessive male hair? See, she has an additional agenda. Like she has excessive male hair, she has to get rid. She feels that she has to get rid. Should I undergo breast cancer surgery? What if I want to have baby in future? So many questions. Now, so regarding information gathering, what is expected from you? You have to ask open questions. Ask about the presenting complaint. You can say Miss Helen. So however she likes to be addressed. Helen, can you tell me more about your problem? How long you're in a relationship? How are things with you and Harry? How is it now? How do you feel? How do you both feel about that? And do you have the get the urge to have the sexual intercourses? Where do you think is the problem? I understand your problems are real and this needs to be addressed, and we are working towards the solution. You should not brush aside their concerns, especially in this kind of scenario. Here you have the lay examiner. Always remember, if apart from your role player, if there are two examiners sitting and watching you, it means one is the clinical examiner, the other one is the lay examiner. So be very, very careful. So they are seeing your soft skills, your communication skills, how the way you ask questions and the way you explain. So ask about, are you okay with Harry? How is Harry treating you? How were things in the past? And like, do you both feel the urge or the need to have the feeling to have the sexual intercourse, about the discharge, any ulcers in the private part, and ask about the partner history. Is he treating you well? And rule out violence. And ask about the other history like BMI, family history, personal, social, mental, how she is feeling about her personal and social and mental are very important here. And you can ask about the fertility plans. What are your plans for future fertility, about having children? Then communication, always say like, greet them well, pleased to meet you, apologize for consultant's absence if any, listen to her story, validate her symptoms. Like, I can see this is really bothering you. I can see that this is, distressing you. I'm really sorry for that. And never be judgmental. Never show some gestures like when she says that she has pain during sex, or like, oh yeah, don't show any faces. Listen to them, look widely into their eyes and listen to them. Give confidentiality if she's hesitant to open up. Whatever you're sharing with me, Helen, it's going to stay with me, and I'm not going to share it with anybody you know or I know. And that is the NHS policy. And give her confidence, and appreciate her self-worth. She says that I'm good at work. She says that I'm supporting myself. Always appreciate her. And if it is a GP letter, especially stations like that, ask permission to write back to the GP. That is always the policy. If they say yes, yes. Now she's having a problem. You understood that she is having dyspareunia, just superficial, everything you've asked, and It is a GRS, gender reassignment surgery. So you need a specialist input. The expertise or the competency level expected from you is the level of from anywhere from S3 to S5. So you have to get specialist input, right? So you have to refer her to the specialist gender surgeons and liaise with sexual health services. And if you need to take swabs, if there is any abnormal discharge, definitely you can take swabs and involve the MDT, the gender reassignment surgeon, and the gynecologist, consultant gynecologist. If she says yes, the GP and the specialist nurse. And psychosexual counseling, she is depressed because of that. Never ever forget. And she may need some relaxation techniques. What do you think, right? The physiotherapist may be involved who can teach her the Kegels exercise, the pelvic floor exercises. Always involve the consultant and identify other problems in trans women, like their fertility needs and whether they've done breast cancer screen. She's 28 now, so DVT is also a risk of them. And she's concerned about the male pattern hair in her, so you can advise waxing, electrolysis or laser removal, and these services may not be available in the NHS, and we have to get it done in a private clinic, which is very clear. So you have to tell it to them. And tell about the incidence of breast cancer in trans women using estrogen therapy, because it's reported, it is same as that of the background risk in that of a male. However, trans women should be screened as appropriately, like women. Fertility, if she says, or you can ask, like, what are your fertility needs? What are your plans for future fertility? So you can tell about, you can conceive, you can have your child with your partner's sperm, and you need a donor egg and a surrogate womb. All right. So now we move on to your station 3. So far we discussed 2 stimulated patient tasks, and today this one is a structured discussion. This is Mrs. Allen Grace, 35-year-old woman who has come for consultation as she received a letter stating that her recent cervical smear turned out to be high-grade scoliosis. She is HR-HPV positive too. So you are an ST5 in the clinic. Your task is to discuss a management plan for this woman with the examiner. You will be assisted on information gathering, communication with colleagues, patient safety, and applied clinical knowledge. So in structured discussion, you may have a lengthy or a short candidate instruction, and you will have 5 to 7 questions which will be asked by the examiner. Remember to concentrate and listen to the question and answer to the question precisely. In each question, you will be allowed to answer. You should be able to finish answering the question at least within 1.5 to 2 minutes. Do not beat around the bush. And if you think you're out of the track, ask them to repeat the question again and try to move to the track again. That's what I could say. Right. So what further information would you like to obtain? What is your next step in management? What will you advise a woman who is waiting for a colposcopy appointment? Like, what all the pre-procedural and post-procedural preparation a woman should make? The colposcopist is of the impression during colposcopy, the grade of the lesion is CIN2. What will be the next step? During the wait time, so the woman becomes pregnant. So will you proceed with colposcopy or not? So let's move into answering each question. So what further information, whether she has any presenting complaint, any abnormal discharge, regularity in her smear, what was the result of the previous smear, was there any, because the patient, this is only the current smear and she's 35 years. So what happened to these smears which should have been done twice before when she was 25 and 30? You have to ask whether any treatment done before, that also has to be asked. And bleeding during smear, and her menstrual pattern, her last menstrual period. Never forget to rule out a pregnancy at present for any patient, like our medical college or the medical school has taught us. Rule out a pregnancy in any woman when there is suspicion. When there is no suspicion, always rule out a pregnancy. So ask LMP regularity, intermenstrual bleeding, sexual history, pain, bleeding during intercourse, sexually transmitted infection, previous history, and partner history. It's important, previous partner if any. Obstetric history, yes, definitely it's very important whether she had children in the past, and the mode of delivery, and what are her future fertility concerns, her BMI, and medical surgical allergy history, because you're going to suggest her a procedure, and smoking history. It's very important, one of the risk factors for cervical cancer. Social history, mental history. So what is the next step? Next step, the answer for this question is very straightforward. And she has high-grade dyskaryosis, referral to the colposcopist for a colposcopy appointment. And this referral has to be done on a 2-week referral pathway. She has to be seen by a colposcopist within 3 weeks. And they should be offered colposcopy within 2 weeks. All right. So how will you explain colposcopy to a patient who's waiting for a colposcopy appointment? How will you say? What all the important points which has to be covered? Your examiner is asking you, so how will you say? So I will say that colposcopy is a simple procedure used to look at the neck of the womb, the lower part of the womb. So it can confirm whether the cells in your cervix is abnormal and determine whether you need further treatment. So you should be seen by the colposcopist. I will say that the woman has to be seen by the colposcopist within 2 weeks. And before colposcopy, for 24 hours, I will advise the woman not to have penetrative vaginal sex and not to use products inside the vagina like tampons, vaginal creams, or medicines. And she might have some minor bleeding after the colposcopy. It's a good idea to bring sanitary pad or panty liner to the appointment. And if she has, if she has any intrauterine devices, she has to inform the person doing the colposcopy. And what happens during the colposcopy? It just generally takes around 15 to 20 minutes. She doesn't have to come empty stomach. She can eat, have a proper meal and come. During the procedure, a device called speculum will be inserted. She will be, her neck of the womb will be looked through with a bright light and some filtered lights, and liquids will be applied, and a small biopsy will be taken. And if there is any abnormal areas, we may do some invasive procedures, like you can say that lids and cone biopsy. Okay, so with this colposcopy appointment, we will not be able to straightly tell whether she has cancer or not. But if there is any abnormal areas, there are treatment to remove the abnormal area and send that for biopsy. All right. So how long she has to get the biopsy reports? Normally 4 to 6 weeks. So what are the treatments to remove the abnormal areas? So if there is moderate to, if we see if we find abnormal areas, the treatment is required to remove the abnormal areas, and there is a chance that it may become cancer if left untreated. The 2 treatment options are large lobe excision of transformation zone, where a heated wire loop is used to remove the abnormal cells, and a cone biopsy, a cone-shaped piece of tissue containing the abnormal cells is removed. So it's usually carried out when you are awake. So, but when we want to do a cone biopsy, that has to be done separately under general anesthesia. So you can explain that. So this is the way I will explain this to the patient who is awaiting colposcopy. So normally, how do we get the results? The result is going to be normal in 4 out of the 10 people and going to be abnormal in 6 out of 10 people. So you get the results and in terms like CAN or CGIN, and it is followed by a number 1, 2, and 3. So when the number increases and this chance of it being the cancer or the severity increases, so that you have to explain. So, so the treatment options, right? So once the treatment is given, she has to be recalled after 6 months. So after lids, the people may have bleeding for up to a month, so there can be a smelly discharge, and they suggested not to go for not to have penetrated sexual intercourse for at least 4 weeks from the procedure, not to use tampons, and avoid activities that could increase the bleeding or pain worse, like deep contact sports and vigorous exercises. They should give the GP number and the hospital contact number. So after treatment, the woman should be called after 6 months and do a repeat cervical sample should be done. So the recall date is 6 months after the treatment, right? So all these I will explain. Obviously, you have to say that. So the answer for this question alone is a bit lengthy. So is colposcopy. So she's waiting for colposcopy, but after a week she turned urine pregnancy test positive. So will you do a colposcopy or not? So any woman who needs, she's HR-HPV positive and also high-grade dyskaryosis. Of course, she needs a colposcopy test, but just to view the area and look for any abnormal area. If biopsy is indicated, that has to be deferred for the postnatal period. All right. So if you suggest there is concerning finding, or if there's a chance of clear-cut cancers, then definitely you can go for an excision biopsy. This is the answer for that. All right, so your answer should be precise and clean. If individual denies treatment, definitely she can be seen in the postpartum period, right? So generally, I'm going for the domain-wise marking in the station. In the station, ability to get focus history on smear and previous smear, ability to get the risk, illicit and risk factors like partner history, sexually transmitted infection history, previous partner, multiple partner, which helps you in arriving at a conclusion. And illicit menstrual marital obstetric history, wants to know about whether the patient has completed family and her future fertility concerns, illicit personal history, especially smoking, illicit social and mental history. Next, the information gathering complete. Communication with colleagues. Present the scenario using medical terms. Avoid patient-friendly terms. Prompt referral. But how will you explain to a patient? There was a question which says, how will you explain to the patient? There you can say that. There you can use patient-friendly language. Otherwise, you have to use, you should use technical terms, the medical terms. Prompt referral should be done within 2 weeks, and there should be a structure and coherence while you explain each point one by one in a structured way, and arrange a proper pathway of care and involve colposcopist and also the GP. Safety. Focused information in order to rule out a current pregnancy, current bleeding, current STI, and any contraceptive used at present, and future fertility plans. Arrange 2-week referral pathway and explain the precautions before and after the colposcopy. No colposcopy is safe in pregnancy. However, biopsy is not indicated except for invasive cancer, which is very, very important. This is the asterisk points which should be expected. It's one of the safety point which has to be told by all the candidates, and just the most expected or the asterisk point in this stage. Applied clinical knowledge. Understand that high-grade lesion has high chance of invasive lesion. Knows that colposcopy is the definitive next step for severe dyskaryosis. If you don't say colposcopy, definitely we are going to get failed in the stage. If you don't say that she may need a biopsy within 2 weeks. Colposcopy within 2 weeks is the key. You don't say, definitely, if we don't say, we may not clear that station. Knows how colposcopy is done by colposcopist. What is that? You should know and you should be able to explain. And you shouldn't have the knowledge how colposcopy. The examiner will assess with the way you explain, and explains the follow-up after procedure, and knows the treatment options like let's inform biopsy are available, and these are the treatment and treatment options, right? So now I'm going into the common mistakes. So now that I've explained 3 example stations, I'm going to talk about common mistakes which candidates may commit. So when there are 2, 3, 4 results given, blood tests, ultrasounds, and urine tests, one of them may be forgotten. Don't do that. So go in a stepwise, explain one by one. And forgetting menstrual history, terribly, it's very important. For example, if you have a woman with tubo-ovarian abscess and her LMP is 6 weeks back, will you do a UPT or not? Which is very, very important. Ask for LMP and do the urine pregnancy test. And forgetting menstrual history. Menstrual history is very important. For example, if you have a woman and she is having a large fibroid, you're suggesting a laparoscopic hysterectomy, but she is a woman who is taking, medication for schizophrenia. It's very important. The condition has to be under control. You need to get a psychiatrist opinion for that. So if you brush that aside, you may terribly fail that station. Explaining too much about the condition using medical jargon in an SVT station, like if you're talking too much about, for example, if you're given a station with fibroid, if you're talking too much about uterine artery embolization, the silicon particles, blah, blah, blah. And if they don't understand about it, it makes the situation very terrible, right? You have to explain it each and every procedure one by one with the pros and cons, and make sure that the role player candidate understands that. Stop and pass and ask if they understand. Not asking obstetric history, very, very important. If, for example, if a woman has come with premature ovarian insufficiency, you do not know whether she has completed the family or not. So, and you don't ask about the future fertility, and suddenly you're telling that you have to take HRT. She thinks that she is 35 years and she has one child, and she thinks that she wants to have another child. So it makes the situation, worse. It shows that you're not a safe person. You're addressing only the symptom. You're not addressing the patient completely. So you should, ask everything about the patient, not asking obstetric history, not asking sexual history in a case with, in a patient who has come with premature ovarian insufficiency or endometriosis, or a patient with fibroid asking for hysterectomy, but you don't ask about the sexual history. It's very important. You should ask, not asking about contraceptive history. For example, if a woman has come with heavy menstrual bleeding, and it doesn't mean that she will not conceive. She can conceive even with heavy menstrual bleeding. So you have to address the contraceptive needs. She has a fear that she may conceive on the top of that. So don't never ever interrupt the role player when they are talking. So she'll be telling doctor, I have this the vulval thing just bothering me. You think that she is eating your time. Don't think that way. The exam is framed in such a way that they will not eat your time. You should listen to them carefully, and they're going to give you a hint on how you're going to perform. So never ever interrupt the role player. Never be judgmental on their personal habits or their sexual history or their family history. Never ask him that she is happy at home. So ask, are you happy at home? How's your partner treating you? And always, I've been always telling, like, ask the LMP and rule out a pregnancy. And ask whether she has been pregnant before. Ask for future fertility concerns. Never tell anything which you're not sure of. For example, if you're going to suggest uterine artery embolization, make sure that your NHS trust has that or not. Without having, you cannot say. You should say, this is an option. Let me check and tell you if we have that option for you in the hospital, right? Certain tips for doing a general gynecology station. Good introduction, confirm name and age, develop a good rapport, ask concerns in the beginning. I can see that you are a woman having heavy menstrual bleeding for the past 2 years, and you've tried intrauterine device, just failed, and now you've come for surgery. So do you have any other concerns? Ask for partner details. Confidentiality is very important. Inquire what they're looking for. Are you looking for? Have I answered your question? Have I addressed all your concerns? Always ask whether what they're looking for. Do they have any other agenda? Menstrual history, like I don't have to talk about that one more time. You have to do that. You have to ask for LMP and rule out a pregnancy. If needed, you have to suggest a urinary pregnancy test. Get a focused obstetric history. Ask and screen for PID, partner support, previous partner, if any. You have to ask that. You have to signpost and ask. Ask blood group and reservation for blood transfusion if surgery is planned. Ask BMI and advise for introduction if appropriate. If appropriate, for example, in PCOS, for example, a woman waiting for hysterectomy and her BMI is 35, you can say that definitely during the time of weight, you can try to reduce your weight. Family history, medical conditions, premature and ovarian insufficiency, endometriosis, personal history, smoking, alcohol, but always any station, any scenario, you can always say good to abstain. Social history, support and mental history, check the background knowledge, what they know about TIVO abscess or what they know about endometriosis. Break bad news if the scenario suggests. Always give options in the most appropriate order and explain each with pros and cons. Make sure they understand. Address the contraceptive needs, psychological counseling if required, and put their concerns in place. Now, the most important one, read the question properly. Many of the candidates fail to pick up whether the simulated patient task or structured discussion, and they fail to pick up specific conditions like allergy. And it would have been already been given that she's allergic to amoxicillin. They fail to notice that, and they don't even ask, and sometimes they fail terribly. So blood group, all these are very, very important. Go through the scenario properly, try to understand. And if you think you haven't read well, ask for 30 seconds or 1 minute extra and go through and Be clear in what you're going to do. According to me, the 2 minutes is more important than the 10 minutes. And if you think you haven't imbibed enough, just take a second, think, and then you can always restart and ask permission. Always. Don't make them, the people or the person sitting in front of you, observed, and communicate with them that you're going to read the scenario again. And look for the domains that you're addressed on. I'm always telling, like, what is being assessed. In structured discussion, be precise in your answer. Do not beat around the bush. Time yourself. You should know, you should be time conscious. You should know when you're at the end of 4th minute and when you're at the end of 8th minute. Oh my God, I think I've finished around 8 minutes. I have 2 more minutes. You have the finishing funda, the writing back to GP, like giving the patient information details. You have to reserve the last 1 minute for. Be calm and composed. Never be in a hurry. Don't have an anxious face. Do not, you know, do not look nervous. Be confident. You've prepared so much, so many hours. So you should be calm and composed, and that is your day. And be confident. Always be confident. You should have a confident voice and a confident attire. Never utter anything you're not sure of. You say that I will get the help of my senior consultant and get back to you. Never give up. If you do terribly in any one station, it is okay, totally okay. Do not carry that move to the next station. So these are the general tips. So thank you for joining with me in this back-to-back YouTube session. Thank you.